Welcome to the HealthManagement.org DigiConf. Show me the money. With our moderator and editor-in-chief, Luis Donoso-Bach, the Epital Health CEO, Hans-Erik Henriksen, Cardiologist, Panagiota Pietri, SVP Patient Insights, Emma Sutcliffe, and Director of Performance and Planning, Janette Hughes. Let us now welcome the moderator of today's DigiConf, Professor Luis Donoso-Bach.
Hello. Good afternoon. It's not Luis Donoso. It is CM for HealthManagement.org, Executive and Editorial Director. I got about half an hour ago a call from my dear friend Luis, and he said in Spain, where he actually is currently located, his region is offline. That means his fiber optic got unfortunately cut. So we just jumped in, and in this case, I'm happy to actually jump in and will quickly moderate the session. Today we have a wonderful topic, show me the money. It's all about cash, the show must go on, and we have a wonderful panel which got already introduced. So Hans, in order to go immediately into medias res, can you please start with the presentation? Thank you very much indeed. You need to unmute yourself, please.
Thank you very much, and thank you for the invitation to present on chronic patients and show me the money. I think it's an interesting topic, and definitely these times we are also seeing some evidence when it comes to chronic disease treatment and management, where we are seeing the evidence and the value. My name is Hans-Erik Henriksen, and I'm CEO of Epital Health. We are a private company. We are a technology company. We are also registered as a private clinic, and we treat chronic patients in their own home using telehealth technology. More than that, we also use a special treatment method. And that special treatment method can be transferred back to a notion going like, what if we had no current healthcare system? How would we treat chronic patients? And as many of you may realize, the answer to that question, at least in the researcher's head who was behind the research, was not to say this is done perfectly in the current healthcare system. No. They took an approach where they said, let's try to break down the barriers between the patient in their home and the hospital, the outpatient clinic, and the emergency room. So that research was initiated in 2014 between a number of municipalities in the Copenhagen area, the University of Copenhagen, and a number of, in this case, pulmonologists, lung physicians. And the conclusion they reached in the research was the Epital care model, a 6-step model where you kind of break up the barrier between the patient in their home and the hospital and the outpatient clinic. In step number 0, you can say that the patient is potentially in risk, undiagnosed for lung disease, which is the current focus we have. In step number 1, the patient's health literacy has increased, and the patient is able to do things on their own. They're knowledgeable about the disease. They know when they have a worsening or exacerbation, they know what to do, and they can handle on their own. In step number 2, they are supported by a call center, which will not only answer calls from the patients, but they will also reach out to the patients based on measurements which the patient do in their own home. The patients have a home kit. In the case of COPD lung patients, the home kit consists of a tablet, a spirometer, and a pulse oximeter. And in step number 3, the lung physician and the COPD nurse steps in and support the call center or get in direct contact with the patient. Step number 3, they can go to the patient's home, a forward reaction team. And step number 5, we have had forward acute departments in the municipalities where the patient can be brought to and be stabilized. And only in step number 6 do you see the hospital having a role. This model, which has been in use in projects in Denmark for 7 years now, proves to be very efficient. We are seeing that when patients are enrolled, onboarded, so to say, their contacts and need to contact hospitals and outpatient clinics and emergency rooms goes down drastically, between 50 and 75%. And there's a very good reason for it, because this mechanism empower the patient, they give it insight. You can say, in a way, in the current healthcare system, when a lung patient have an exacerbation, what they can do is call an ambulance or go to the emergency room. When they're knowledgeable, they're supported by the call center and the physicians, and they're able to take action themselves. And the consequence is that worsenings are discovered very early, at a very early stage. Interventions can be made at a very early stage, and that keep them healthy and avoid these exacerbations to develop to something that is a more serious infection and need treatment by the hospital. There's now also, because this has been running for some years, some good evidence on what it means to patients. The quality of life increase, the life years quality, according to the quality standard, increases. And for the healthcare system, we have evidence for general use of telehealth technology in Denmark in big-scale projects, suggesting that we save 1,000 euro per patient per year. In the national business case, the estimate is 1,500 euro. And in the latest results based on the Epital care model, the estimated saving is 2,300 euro per patient per year. And there's a good reason for this, because the savings are coming from the hospital side. You all know that can we save an inpatient stay of 2 or 3 days, or even an outpatient visit, or a contact at the emergency room, it makes a big difference. As part of the study, they also took one particular patient and meticulously followed all contacts during the year for that patient. Afterwards, they could see that the number of contacts fell to almost 0. What was interesting was that during the year they followed, the patient had actually traveled 2,900 kilometers to different departments. So there's actually also a green effect in treating patients this way. Delivering healthcare to chronic patients this way also allow us to collect data on a much detailed level that we do today. Our patients, they measure themselves once or twice every day. They're mandated to do that in order to be able to track their disease very closely. And that means that we are collecting 75 data points per patient per day. That is a perfect data background to use predictive health. So at the moment we are testing prediction technology in order to not only react the moment we see a red condition from a patient, the same data has been registered, but also being able to forecast this patient is in high risk of a red condition in 1 or 2 days. So the call center and the physicians actually can act even more proactively. And as you can imagine, there are even more potential to this kind of algorithms and predictive health technology, also in the details of medicine use, what is most efficient, the view on the patient's mental health. Anxiety is often an issue with these kind of chronic patients. So definitely, when it comes to chronic disease management, treating patients in their own home, I think for the first time during the last couple of years, we are now seeing solid evidence that there's a huge benefit for the healthcare system, for the patients, and also in terms of how many years the patients live healthy with that disease. So thank you very much for your attention. Thank you.
Thanks, Hans. As usual, you're not only knowledgeable, but you're passionate, and that's what I admire you ever since we met quite a few decades ago. So thank you so much. Now the next panelist is Panagiota Pietri from Athens. Please, what do you have to tell to our audience?
Thank you very much. It is a pleasure to be here today to speak about a hot topic, like it is the psychosocial effects of the COVID-19 pandemic. And this psychosocial impact of COVID-19 is due first to the COVID-19 pandemic itself, and we'll talk differently to general population and the healthcare workers, and second to the imposed restrictions. What is the psychosocial impact of COVID-19 to the general population due to pandemic itself? Numerous studies have shown that there is an increased adverse effect of this pandemic on psychological input. In Chinese individuals, prevalence of depression and anxiety were almost 48% and connected to social media exposure. In pregnant women, a study from Canada, 57% reported clinically increased depression, more than 30% reported elevated worries, and almost 20% elevated insomnia. What is the most important is that the social support was associated with lower mental health problems to these women. Another study in a Norwegian general population, socioeconomic disadvantages and pre-existing mental health vulnerabilities were associated with a higher level of psychological distress and a lower level of life satisfaction. To the healthcare workers, the burden is very high. A meta-analysis included more than 33,000 participants showed that 1 in 5 healthcare professionals report symptoms of anxiety and depression. Almost 4 in 10 experience sleeping difficulties or insomnia. Rates of anxiety and depression were higher for female workers and nursing staff. Another study in China, 45% of frontline COVID-19 medical workers had sleep disturbances. Females worse sleep quality than males. Among 50,000 healthcare workers, almost half of them had post-traumatic stress disorder. 40% experienced anxiety, 37% depression, and 37% distress. Now, the most important is the psychological impact due to the imposed restrictions. The lockdown phenomenon and the lockdown effects among 300 adults in 64 cities in China, 38% worked from home and 25% stopped working due to the outbreak. Those who stopped working reported worse mental and physical health. In the general population of China, a large population, 35% of people experience psychological distress during the quarantine. Women, individuals with higher education, and older people were much more vulnerable to develop post-traumatic stress symptoms, in contrast to young people. And the children, of course, are affected. The children are affected also by this pandemic and the lockdown measures. In England, the incidence of mental problems in children rise from 10% in 2017 to 16% in July 2020. More than a quarter of children aged 5 to 16 years and young people aged 17 to 22 reported disrupted sleep, and 1 in 10 often or always felt lonely. 44% of young people with mental health problems reported no seeking help because of the pandemic. And another dramatic phenomenon is the increase in domestic violence due to the lockdown and the hard restrictions. In China, a police department reported a tripling of domestic violence cases in February 2020 compared to February 2019. In the UK, a project tracking violence against women noted that deaths from domestic abuse between March and April 2020 have more than doubled compared with the average rate in the previous 10 years. In Greece, where I come from, there was an increased number of deaths due to the domestic violence after the withdrawal of lockdown. So the problem is important. We have a new pandemic. This is the pandemic of mental health disorders. After the first wave of the health burden, which is the wave of COVID-19 patients, there is the fourth wave, which is the psychological burden. Apart from psychological impact, there is another social phenomenon that needs attention. This is the social division, a vaccine-related social phenomenon. People are divided into vaccinated and non-vaccinated. A social worker from Canada states that the COVID-19 pandemic has served to divide some relationships with loved ones along the lines of vaccination. While in some cases there may be valid reasons for refraining from vaccination, such decisions have repercussions. Given the tensions that COVID-19 vaccination disagreements may cause, relationships may take more work to maintain. Sorry. Oh, I'm sorry. So we have a new pandemic, the pandemic of mental health disorders. What are the proposed measures to deal with this pandemic? As I wrote in the cover story, Show Me the Money, lockdown and quarantine measures may not be the key answer to the pandemic limitation. A return to normal living activities with adoption of healthy protocols and frequent diagnostic tests may be a more effective strategy for both disease control, economic stability, and for the decrease of mental health disorders. Emphasis should be given to patients with chronic psychiatric diseases or newly pandemic-related psychological disorders. Growth of infrastructures focusing on psychiatric support are warranted. The division of people into two parties, the vaccinated and unvaccinated citizens, is harmful and should be avoided. Unvaccinated people should be encouraged to get vaccinated, especially the elderly and the most vulnerable patients, without imposing penalties. Healthcare workers should manage patients efficiently and equally, independent of their vaccination status. And to conclude, both governments and society should work to alleviate the adverse effects of this pandemic. Hard restrictions, punitive measures, social division are harmful and should be avoided. By contrast, implemented measures with human orientation may inspire people and lead to the successful management of the pandemic. Thank you very much.
Panagiota, thank you very much. Wonderful presentation. Very, very interesting. And yes, indeed, it really pushes everybody to an edge. For example, we have now really a division and it goes further and further, but we will have to overcome this. I mean, when I spoke to lots of people here at Medicare, are you going to RSNA? And they say, no, we can't travel because there are always lockdowns and curfews and whatsoever. So now I have very great news on all the different streaming platforms. We have currently 274 attendees, and we will not want to lose them. So we come to Emma Sutcliffe. Please start your presentation.
Hello, everyone. Let's just not take a measure of people after my part of the presentation, because if the number's gone down, that won't be good for my ego, certainly. I'm just going to get my screen up to share, and I'm just going to ask you to bear with me while I'm just checking that. Does that slide move? Does everyone see that moving? Okay, that's good. All right. So I'm Emma Sutcliffe. I'm absolutely delighted to be here. I've written quite a lot of things for health management for quite a few years now, and they're always willing to welcome an opinion from a patient engagement expert. And I'm very grateful that they do that. And I'm very grateful that they've given me some time here today. So thank you so much. I am amidst great company. So, please be kind as I present what I'm about to say, because I am going to be quite bold, and I am going to make a presentation on behalf of patients everywhere, which is a very bold statement to make. At Prime Patient, my role is to manage major patient engagement programs on behalf of our pharmaceutical clients. And over the years, it's been an absolute delight to me that our pharmaceutical clients have moved quite significantly from just providing fantastic medicines to providing engagement programs that activate patients, educate patients, and are alongside that need for us to build up the health literacy with patients. So I have to also give credit to the clients who have given us this work, because they've recognized that patient engagement is an important part of the medicines and the services that they provide. So this is about Show Me the Money. And I'm really delighted that we're being so forthright in making that the title of the webinar and the title of the accompanying health management articles. When we look at the money and when we look at the milestones in patient engagement, we are actually working within what is now described as the patient economy. So we already start to get those financial terms, and we can see how that patient economy has come to pass. So my clinical colleagues on the webinar here will recognize these milestones. So World AIDS Day is on the 1st of December, and this year it marks 40 years since the first cases of HIV were reported within our clinical community. And what we see is really from that patient engagement perspective, that was the start of the build to this patient economy. So you can see all the milestones there. What we had back in 2012 was a health tech journalist and a digital journalist with a very big aspiration saying, actually, patient engagement will be the next blockbuster drug. Now, that's very bold. But what we then see is Laura McKeveny, who exited Novartis at the end of last year, and she was the global head of patient engagement and advocacy there, saying that actually within Novartis's walls, patient centricity and engagement now does have a transferable business value for a company. So in terms of what does patient engagement do? Well, we are operating in a patient economy, and this is what it does for pharma. It accelerates their assets through the pipeline. So there are really three fundamental parts to patient engagement. That's awareness of their asset and awareness that they're creating new solutions for clients, for patients. That's activation of the patients to be able to understand how to use new medicines, new devices, new services, and to activate them again to be more involved in their self-care. And I'll come on to some facts in a minute, which really do iterate what Hans said earlier around the more activated a patient is, the fewer health resources they consume. That's a big saving. And to Panagiot's earlier presentation too, what we also see is that there is a huge psychosocial benefit to activating patients, to helping them to understand the consequences of their involvement or their lack of involvement in healthcare decisions. So yes, patient engagement brings a pharma asset through the pipeline more quickly, and we get to the stage when we are delivering an amplified value of that patient engagement progress right at the end of that pipeline. But what we also see is there are triple win benefits here. The more activated a patient, the fewer health resources, the sooner these products and medicines are with patients. So ultimately, it's a triple win. Patient engagement really ensures better outcomes for patients, better outcomes for society. And that cannot be anything other than a fantastic triple win. So how does this translate within our business world if we're still talking about Show Me the Money? Well, what we have seen now from a good decade of different kinds of patient engagement programs is that the triple win is achieved. Engagement has a benefit in every part of our healthcare system. So we have a lot of data now, a lot of published studies that demonstrate all these proof of purpose points. So it does lead to improvements in the delivery of medicines and services. It improves compliance and adherence to treatment. It's a unique therapy in itself, enhances stakeholder relationships, and by that it means there are better conversations about health going on between a patient and their healthcare provider. It really does anchor organisations into that global healthcare structure, and it does add to that sustainability model as well. We cannot keep our healthcare costs rising and rising and rising. We have to do something that starts to do some part of amelioration around that. So we can achieve that triple win. What we can see is the more there is a patient engagement program provided by pharma, provided by a healthcare organisation, it takes that passive experience for the patient. Things are done to them. Things are asked of them. It takes them to that next level, which is when they're more activated. And they report that they feel heard, they feel informed, they feel empowered. And then the next stage, the ultimate stage to reach is using the actual patient activation measure. And we know that as people go up that scale, and it's a 100-point scale, there are 4 main areas of it. They are the clinical indicators, preventative screening, healthy behaviours, and cost utilisation. The more activated a patient, the higher their patient activation measure score, the better impact on health outcomes and costs. And we can see that if we really put it under the microscope in terms of actual outcomes. So a pharma asset and medicine that's been through the pipeline with a patient engagement program in accompaniment is 19% more likely to make it to market, because the research is gathering experience information from patients, which is what our regulators are now asking for. So it's a no-brainer for a pharma client to include patient engagement in asset development. We can see the numbers there around engagement programs, increase adherence, reduce lack of compliance, and there are so many compelling facts that demonstrate that patient engagement delivers that ultimate triple win. And let's be really honest, there has to be a return on investment. Anybody who is investing in a patient engagement program, they have to have 4 very clear reasons for doing that. And the reasons are very clear. So what we can see is that engagement programs have to be in place legally, they have to be in place ethically, they have to be in place financially, and they have to be in place logically. And you can see some of the data there. But there is no reason to ignore or to exclude a patient engagement program from your delivery of service. And we can be direct in our response. There is a return on investment, and that is very well demonstrated. So we have a plethora of studies out there now, and there's more and more adding to the evidence bank of data for the investment return for patient engagement programs. So whichever aspect you're coming from, pharma, healthcare utilisation, patient support, there is enough evidence now to be confident that patient engagement programs deliver a return on investment. So just coming to the end of my presentation now, we're also asked to look at the impact of COVID on patient engagement, on utilisation of resources. So there are 2 very clear things that have impacted on the patient potential from the pandemic. So if we look specifically at the impact of COVID on clinical trials, it has really moved how we run trials, how we recruit into trials, the kind of people we recruit into trials. This actually has really changed what it means for patients to participate in clinical trials. And some of the data is given there. But what always jumps out to me is this diversity aspect. So the US Operation Warp Speed vaccine generation program, it encouraged people from diverse backgrounds, including those who are most at risk from COVID, such as Black and Latino people. I've worked with several pharma companies who have oncology products and services, and they were able to create hybrid trials such that people could send their data in from their own home. So what's happened from the trial perspective is COVID has forced us all to take a fresh look at how we help patients to participate in clinical trials. the diversity of clinical trial and the inclusivity of clinical trials, and also the convenience of people participating. So we're really hopeful that there's a new era now for patients of clinical trial participation, and COVID has been part of the promulgation of that need for change. And then just finally, what we do see is that the patient engagement support programs that pharma provided during the pandemic really worked for people. So we can see that the impact that COVID has had on that pharma, patient, and public relationship. And fundamentally, we need to have confidence that our pharma and research industry will deliver products and services that we need. And we really saw this, certainly during the information and the infodemiology part of this pandemic. So just a few facts on there. And I wrote this for Health Management last year, right in the eye of the storm, as it were. What we are seeing is that there is an adjuvant therapy part to providing information and support programs for patients. We've seen that there's a sense that there's a broader collaboration to be had. We're more open about the support that we need. The veracity of the information that pharma has provided in their patient support programs during the pandemic has been excellent. Now, one of the things that was being reported was that we are going to have a mental health tsunami following this, which is what the previous presenter just described has happened. And it fell upon us within pharma and within health education to try and do the best that we could do to make sure that the internet was a useful source of health information. So we're now starting to see that social media channels are being used as part of health management. And that's a really great way to share good information and mitigate inappropriate comments. And what we've actually seen overall in terms of that pharma-patient-public relationship is we can start to trust industry again, that they will collaborate. There will be this multi-agency, multi-company, multi-disciplinarian way to trust industry, to collaborate and create the treatments and vaccines and provide that extra supportive care that we need. So if we look at the show me the money question, there is absolutely no doubt, just in conclusion, that we can achieve triple win thinking when we include patient engagement in all aspects of our provision of care. So medical care and research collaboration needs to have patient engagement as a natural adjuvant to ensure the success of those programs. And again, the facts are here and you can read them. I'm not going to read them out to you. But there is no doubt now that there is demonstrable return on investment and that patient engagement programs and support does deliver triple win objectives. And that's better outcomes for patients, better outcomes for pharma, and better outcomes for society. So on that note, I shall stop sharing and kind of pass over and say thank you again for inviting me to present.
Thanks,
I
Emma.
hope that was a useful summary.
Thanks, Emma. It was very interesting. I mean, the pharmaceutical industry had spent $16 billion in 2020. So, and now, given your enthusiastic cause, this was basically only spent in order to improve the patients and mainly spent that the pharmaceutical industry supports the patients. Is this correctly understood?
I'm sorry, I don't understand your question. Spent $16 billion on what?
On patient engagement. The whole pharmaceutical industry has spent $16 billion on patient engagement programs. Yep. Now, 90% of all patient engagement programs are actually funded by the pharmaceutical industry. Doesn't this worry you? In particular, as there's more and more proof that actually these patient engagement programs are highly moderated as well in favor of the pharmaceutical industry. And this doesn't worry you?
That's the first time I've heard those figures. So that's a bit of a big thing to ask for me to respond to on the spot. So I'd like to know a bit more about those figures. Of all the clients that I work with, their patient engagement programs are welcomed by patients, are welcomed by patient advocacy groups, and all the pharmaceutical companies are very ethical in their reporting of their spend.
All right.
So yes.
Then everything is perfect. Thank
It's
you,
not
Grace.
perfect. No, everything
Yeah.
is not perfect. So please don't conclude and put words in my mouth in that way. We don't have a perfect system, but there is no doubt whatsoever that patient engagement activates patients. They can take their own self-care into their hands too, and it does deliver benefits for patients, for pharma, I did not neglect from that point, and for society.
Now, what I would like to see, as you have a very close relationship to the pharma, that is 16 billion. Let's say half of it would go to independent bodies, not influenced by the pharma, and that actually the patients could really organize their own patient organizations. Because I have met a few people within patient organizations. Mm-hmm. One was running the largest advocacy group. I cannot mention a name because it's a dear friend. And he was one of the key managers as well within the pharmaceutical industry. So my wish in the Show Me the Money is, guys from the pharmaceutical industry, show me the money, put it on the table, but let us as a patient spend it and don't influence it. You agree?
I'm not going to agree to that comment. No. Not going to agree with you.
Janette,
I think you're kind of setting me up there to be the
No.
scapegoat for
Okay,
pharma,
next
and I'm
one.
not going to be the scapegoat for pharma.
We have, of course. We have anyhow. Now, Janette, sorry,
okay,
but it's a very enthusiastic point from me. So I love this. Okay. Janette, thank you, Emma. You're the next one. Yeah.
Thanks, Christian. I'm just going to try and share my slides, so please bear with me for a second.
Great.
Hopefully, do you see my slides?
Yes, you press slideshow and then it works perfectly fine.
All right, okay, thank you. Sorry. Okay, well, firstly, thank you very much for inviting me to present. I'm delighted to be part of this webinar. My name's Janette Hughes and I come from Scotland. I am Director of Planning and Performance for the Digital Health and Care Innovation Centre. And my presentation today is really talking about the impact in Scotland and some of the digital health and innovation that we developed as part of the COVID response. So thank you. Moving on to my first slide, I suppose like many governments around the world, when we talk about money, we talk about funding as well. And many governments had to pull together a funding package to respond to COVID. And that was really for Scotland and highlighted in some of our government reports to really protect the 4 key harms that COVID was bringing with it. Those harms included direct health impacts, indirect health impacts as well on the wider population, the societal impacts about the restrictions that it was placing with the population. The population of Scotland is 5 million, and the economic impacts with regards to the provision of direct services and obviously stopping industry move forward with those restrictions. Our funding in Scotland for the COVID response in 2020-21 was just under £10 billion. So again, when we talk about money, we talk about where is the money coming from to actually fund some of the innovations and developments to respond to such crises. Another question that was raised as part of this panel discussion was how can healthcare reduce the cost of chronic disease? And obviously COVID is included within that. Within DHI, and I was delighted to hear Emma's presentation about being patient-centred. We are very much patient-centred, and we believe that actually a lot of the cost can be taken out if we move the cost of treatment from the hospital environment into the environment of communities. And that is around how do we prevent crisis? How do we prevent things when we talk about chronic diseases like diabetes, like crisis situations with COPD, and how do we allow more services to actually take place within the person's home to reduce cost, but also to increase accessibility. and improve service delivery for the healthcare sector. So going back to the COVID response and some of the novel solutions and tools that were developed, we developed a number of tools in direct response to COVID. Things like the National Notification Service, which allowed, and we developed this within 52 days, which helped people and helped the public health resources that usually would have to telephone from call centres, everybody that maybe had an instance of COVID, help them digitalise that very quickly so that the population would understand whether they were positive or negative. We also incorporated decision support tools into the clinicians' hands around COVID, and also an article that I wrote specifically for the Health Management magazine was around hospital at home and heart failure patients being treated in their own home. And that was small scale pilots undertaken in the Netherlands and also in Belgium. Now, one of the key points that comes back to show me the money is the evidence that you need to scale these innovations. What you need to understand is that at the end of the day, there will be a finance director, and that finance director will be asking for return on investment, cost effectiveness, cost benefit analysis. And the article that I wrote highlighted that actually a lot of the projects within digital health and care take a long time to get to a project pilot, maybe an RCT, but along the way, you have to have cost effective and cost indicators that actually it is viable and feasible to actually scale those innovations. Moving on just to the negative notification service and the difference it made to the bottom line. I suppose, again, it's about building capacity and cost avoidance, especially when in the eyes of COVID, we didn't have the luxury of employing more staff to actually come into positions. So with this negative notification and positive notification service, we actually managed to optimize using the digital channel with 75% actually doing self-service within 45 minutes of receiving a positive result. Now, what we can glean from that is that that saves time for the actual service, and especially in the face of a pandemic, which again, nobody had planned for, so they didn't have the resources in place to fulfill that requirement. I suppose as well, the other question posed to the panel was, what's the impact on the healthcare industry after COVID? And I think there's key lessons and points to be made here. When I talk about industry, I talk about suppliers, I talk about the health service, I talk about the workforce and the skills, the patients, who are the customers to this service. And I think a few things have definitely changed. One thing is the demand for industry solutions has changed. Therefore, there is a bigger demand for digital tools for healthcare providers. And I think that, again, going back to show me the money, will actually be a positive for return on investment, because people can actually see how this can be scaled at pace. I think the second thing to consider about the impact is customer demand. People in all countries around the world have been dealt with differently from their healthcare services. And I think the demand and expectation going forward will be very different. People will expect more digital within their service. The workforce and skills have been optimized. And again, that can be only positive when you talk again about cost benefits and return on investment and being cost effective. Now, we know that the tsunami around skills is here. There's definitely a skills shortage. And therefore, that argument and case can be very much optimized, I suppose, for that investment to be made and for finance directors to show the money to improve the services. Fundamentally, there's new models of care now, that weren't here before the COVID crisis, that are now here. And I think the customer would not want to regress back to traditional ways of working. So from my perspective, and the article I wrote for Health Management, it was really highlighting how certain tools can help build that case for scale and use the evidence around return on investment, cost effectiveness, health-related quality of life. So that brings me to the end of my presentation. So thank you for listening.
That wonderful presentation. Thank you so much as well. Really, really interesting. Now, what I really see, we had so many crises. We had the bubble crisis, we had the bank crisis, we had another bank crisis, and now we have a healthcare crisis. And given what at once money was made available in healthcare for testing, for telehealth, whatever, this was quite interesting to learn. What for you, Panagiota, would be the biggest takeaway out of this? Please unmute yourself.
Okay, this crisis, this COVID-19 pandemic, as you said before, has brought many changes in healthcare systems, in our lives, in our economy status. I think that speaking about money, and show me the money, I think the money here in crisis, the one that has the most benefit from the money are the pharmaceutical industries, as you said before. I think money should go to patients, to treat patients, because as I said before, when COVID-19 pandemic will end, which I hope it will end soon, another pandemic will arise and we have to face the mental health problems pandemic, the economic pandemic. People will lose jobs. Okay, there are opportunities for healthcare, for digital healthcare, but we have to concentrate on human.
Absolutely, absolutely. Now, Emma, very quick one. How would you see that patient engagement can facilitate and accelerate drug development?
Well, as I explained in the presentation, at every aspect of the pipeline, right from awareness of what the needs of a patient are, right through to delivery of a service. And I think we need to bear in mind that pharma no longer just deliver a pill, they also deliver digital devices, and they also have a very strong monitoring set of services and also diagnostic services. And those things come to fruition in the provision and support for chronic conditions. But the way that specifically patient engagement facilitates drug development is that engaging patients in clinical trial design means that the right kind of product and service is then delivered at the outcome. So the earlier you engage with patients to create your clinical trial program, the better. And that comes down to literally as practical a thing as how many site visits does someone have to do? Are we expecting them to have to get up and get to a site really early if they have Parkinson's disease and they can't actually be mobile until their meds have kicked in? So involving patients at the clinical trial design is key, including patient-reported outcome measures and patient-reported experience measures is now a key part of that development pipeline. And that is speaking to the patient experience of our healthcare systems. And the regulators now expect PROMs in clinical trial design and PREMs in clinical trial design. So if a pharma company gets to a regulatory dossier and it doesn't have that patient experience measure or that outcome measure, then they are not going to get their drug past the regulator. And part of that is saying, what impact does this medicine have beyond just the symptomatology or the curative approach or the functional cure, as many medicines now are, but what actually does this provide in terms of the patient's overall life? So at every stage of that drug development pipeline, patient engagement improves the service and the product. And as they go through that, the support they receive in terms of education and activating them, understanding the importance of participating in screening and monitoring, that activates the patient in terms of their self-care and their dialogue with their healthcare providers.
But in all this, what you say, which I completely understand, one question I couldn't answer myself yet: why aren't more pharmaceutical companies investing in tackling, let's say, malaria or antibiotic resistance? Do you have any explanation for this?
They are businesses. And I was very clear, and I never shied away from the fact that better patient engagement delivers outcomes for patients, for pharma, and for society. So they are businesses, they do have to return a profit. I would like just to speak to the earlier comment in that if you look on record, Emma Walmsley, the CEO of GSK, made it very clear that the company would not make any profits from vaccine production and delivery, and they would put any profit they make back into vaccine research. And whenever we hear about the Oxford AstraZeneca drug, if we look at our media, every time there's a benefit about that vaccine, it's described as the Oxford vaccine. Every time there's a problem with that vaccine, it's described as the AstraZeneca vaccine. So I really think we need to take a good hard look at ourselves and see how we are contributing to that negative concept, because patients don't want to hear it. They want to know that healthcare organizations, pharma companies, and their physicians are collaborating to give them solutions. So arguing in the background doesn't do anything for patients, doesn't bring solutions through.
Yes, you have a point, but Pfizer is making billions.
Yeah.
How does this work then?
Yeah, Pfizer is making billions, and Pfizer is also putting billions back into research. Just a moment, please. And having seen recently an initiative from the European, from the contract they made with the European Union. Can I just clarify that my role here is to explain patient engagement and the benefits of it. I don't work for
I understand.
I don't come from FPIA and I don't come from the ABPI. So you're criticizing the wrong person. I'm here to represent the merits of patient engagement.
Absolutely. But I need to understand, and for our visitors, we need to as well understand how ethical is the patient engagement progress, or is the overlaying engagement in order to sell more drugs? So that's the question. And this is what I want to figure out. I know that you're
the patient engagement programs that I am a part of, I deliver and I oversee and I recommend are to enhance patient engagement. I've presented very compelling data about the benefits of those for patients.
Okay, no. It's not a criticism, but these are questions because I've here chat.
No, you've repeatedly asked me about the profits that pharma makes, and I've repeatedly explained to you that I'm trying to demonstrate the benefits of patient engagement for all three parties, predominantly for patients. I cannot defend pharma's profits because I don't work
you shouldn't.
In any pharma.
It's not your job. Absolutely. I completely understand your role. You are nothing else than the transformer engaged who is actually the facilitator of patient engagement. I'm fully aware of this. Absolutely. But nevertheless, these questions are asked me, so I just need to do this.
But I can't answer those questions. I cannot answer those questions.
Absolutely, but perhaps we will set up, perhaps in the future, a dedicated discussion with those people who can do this. And
bring the CPO in, bring the Chief Financial Officer in of Pfizer. Don't bring the patient engagement expert.
No, you're completely, that's a very good thing. The next guy we will invite the CFOs. Lovely.
Grill them, don't grill me.
I don't grill you anyhow, you're way too lovely. So quick focus here. Now, having seen how much money poured into the business, and indeed money has changed engagement patients are significantly stricter when it comes to their demands as being treated as a client and not anymore as a patient. So this has really changed in the last 2 years, accelerated even with COVID. I see this positive. Now, Panagiota, what would you see? Where is your wish and your dream when it comes, show me the money? Where should the healthcare system show you the money, and what would you do with this money?
Well, my dream is, as I said before, the money to return to people, to patients. We should concentrate on the human, because now the human crisis is really huge. It's not just the health crisis, it's not economic, it's a human crisis. It's a historical moment what we are going through, and we should return to human, and we should focus to human needs. We should do this reset. The great reset should be the human needs. That's my dream.
Do you think is this dream realistic to be done, or are there too many other parties involved who actually prefer this reset in their own favor? What is your personal feeling?
My personal feelings about?
Well, what would you feel?
You mean about
There's the dream. There's the dream, but how realistic do you think is it that it will really happen, that the money goes back to those who are in need and to those?
Okay, for example, in Greece, the government should spend money, should invest money to public health, to primary care. Investment should be made to primary health care.
Absolutely, absolutely. Hans, what would be your dream? What would you envisage when we would have money, or the money we have, how to spend, how to redirect to get a better outcome, who get a healthier life? Please unmute yourself.
I think many of the keywords has already been mentioned. It's about it's about getting the data from the patient. It's about getting closer to the patient. It's about primary care, moving healthcare closer to the patient. And first and foremost, the patients, they want it. We saw that in Emma's presentation. We are seeing that in our services. Our patients, they have access to free healthcare in the public healthcare system of Denmark, but nevertheless, they pay us a monthly fee to treat them as chronic patients because they see that they get a better treatment. And the healthcare service is making the big savings while the patients pay themselves. I think that's interesting, and I think my dream would be to see a world where we are moving healthcare closer to the citizen, but we are also leveraging public-private cooperation much more than we do today, because there's a lot of potential in that, as Emma also pointed out. There's also some issues. There's the issues of confidence and trust, building trust between private companies and the healthcare authorities. But we have seen during COVID-19, at least in Denmark, a lot of private-public cooperation, which suddenly happened because it was necessary and it was successful. And everybody trusted each other. So I think we can learn from that. And if we can do that, there's a huge potential in leveraging what, for instance, pharma companies are doing in patient engagement and what we are doing as a private healthcare company. But of course, we need to have the right confidence and trust behind it.
Absolutely. Thank you for a wonderful statement. Now, last but not least, Janette. Given this idea, this vision, what would you do if you could spend the money in order to make the patients much more happy?
Yeah, I think the realization is that COVID has shown us that you can accelerate and scale digital health for the benefit of citizens and also of services. So I suppose my dream would be that every government, this isn't just a Scottish government, but every government around the world's spends more money on actually taking their pilot projects and making sure they have budget to implement them, adopt them, and scale them to sustain them. There's too many projects in digital health that are sitting at pilots, and that is global. There's not one country that doesn't suffer from that. And that's because they're not investing on the sustainability and the scale of those innovations. So my dream, and I think COVID has proven this, that the citizens are accepting of innovation when it benefits them. So I think governments should really start shifting up a gear and accelerating the realization of that.
Thank you so much. This was a wonderful statement. It's a wonderful vision. And I think everybody in the panel is really here supporting this, because indeed, many pilots, not many actually start flying. And I think there's definitely a big thing. Emma, thank you. You have really held a very strong stand. And I love your work. Don't get me wrong. You do an amazing work. Hans, we know each other since so many years. I always admired you. Panagiota, Janette, absolute to everybody, thank you. We've had a great talk. We a few minutes longer, and thank you for having me as a last second step in moderator. I'm not necessarily the nicest guy, but I'm proud that you write for our journal. Thank you very much indeed. Great, great, great. And hopefully we get soon new articles from you. Bye-bye. And thank you for listening to us.
Thank you.
Bye-bye.
Thank you. Bye.
Thank you.